Just a little bit about the DCAN network. We're an open, diverse, action-focused network. It's a space for bringing together the worlds of dementia and personalisation, which is about focusing on what matters to people in their life and then understanding what we can draw upon to help them achieve it. This is a task that's bigger than any single part of the health and care system. It's started off looking at the NHS's personalised care model, but to really achieve personalisation, people with dementia, it needs to be much bigger than just one part of the system. And so DCAN is a space where we can come together and learn about what's required to create change and improvement, and then find and explore ways of supporting that change through collective contribution of all of us. So DCAN events and membership is made up of people who have dementia, who have care and responsibilities for someone who has dementia, as well as a range of professional roles across voluntary sector, the NHS, social care, as well as research and academia as well. We are supported by a small core team that's made up of people who have other roles within NHS England, Alzheimer Society, the Coalition for Personalised Care, as well as Think Local, Act Personal. But as a network and with our events and contributions, we're open to everybody who has an interest or has some learning or insights to share to help us move forwards with personalisation and dementia. Thanks, Kira. Next slide. Oh, no, not the next slide. This is the point I'm going to hand over now to Keelan, who's going to share a brief presentation on the findings from the recent Alzheimer Society report. So Keelan, over to you.
Thank you very much, Ian. I'll just wait till the presentation's full screen. So, hello everyone, my name is Keelan Arblaster and I work in the policy team here at Alzheimer Society. So, as Ian said, I'll be talking to you about our policy report on support after diagnosis, titled Left to Cope Alone, the Unmet Support Needs After a Dementia Diagnosis. It's part of a broader project that we've done on the dementia pathway as a whole. So some of you have seen our original pathway report that we released in 2020, and then following that we released 3 reports on diagnosis in 2021. So the presentation will take about 20 minutes. There's a lot of detail in there, but please do put any kind of questions or comments in the chat as I'm going through. Next slide, please, Joe. So for background to the project, we essentially wanted to answer 4 research questions. And these were, what do people need from support after diagnosis and from an annual dementia review? And then are these needs being met, and the impact on people affected by dementia, as well as the wider health and care system if those needs aren't being met. So in terms of to gain an understanding and build evidence, we undertook a literature review, ran online surveys, held focus groups and conducted individual interviews with people affected. And we also commissioned research to understand South Asian experiences of support after diagnosis too. And then to kind of supplement this, we also conducted interviews with 39 healthcare professionals, crossing over primary care, so GPs, secondary care like memory services, community and acute care. And we also engaged with our own support services as well. So in total, there's over 2,000 people affected by dementia contributed their views and experiences to this report. Next slide, please. So what essentially is the challenge? So as we all may know, dementia can be a complex condition, and it crosses over primary, secondary, community, acute and social care. And this complexity inevitably leads to a lack of ownership of the condition within the health and care system. And this creates variation in the quality and type of support people receive. So funding for dementia services also, it's also limited by the cost and kind of staff capacity, meaning these services struggle to consistently offer people with dementia the support they want and need. And starkly, because of this, our kind of survey found that just 16% of people told us that they had received enough support from local services in the previous 12 months. Next slide, please. So to support the kind of provision of effective annual dementia reviews, we asked people affected what outcomes they wanted from their review and essentially asked them to rank their importance. So very briefly, these 7 outcomes are outlining care at end of life, getting the right care for support needs, understanding what support is available, understanding how to manage dementia in case of an emergency admission, understanding how dementia is progressing, considering needs for other conditions, and finally, considering dementia-specific needs. Next slide, please. So we know what people need and want from an annual dementia review, so we wanted to look at whether these needs are being met. So firstly, we know that people are not accessing reviews in a consistent way. So national guidance prescribes that people should have a review every 12 months, but we found just a quarter of people had a review in the last year. And while not all people were accessing a review before COVID-19, the pandemic has inevitably led to a drastic drop in the number of people receiving one. And the reasons for this is firstly that primary care changed to remote delivery of healthcare, which may have adversely affected people with dementia, given that many people with dementia are older people and they're less likely to engage in technological solutions. But another issue is that annual dementia reviews are contained under the quality and outcome framework, and I'll refer to that as QOF going forward. So this is a pay for performance scheme aiming to improve the quality of care patients receive by rewarding GP practices for the care they provide. So to free up capacity to respond to the challenges of COVID-19, NHS England did agree to suspend the dementia QOF in July 2020, and then once again in December 2020 as well, or 2021, sorry, to support the delivery of the primary care-led rollout or the vaccination programme. And we believe that these suspensions led to less people with dementia receiving a review. Next slide, please. So the next issue is that when reviews do happen, their quality can be variable. So over half of people reported to us that it had not helped them or their loved one manage the condition. And people also told us that their support measures rarely changed after having a review. And one reason for this is the lack of standardised and structured approach to QOF, to reviews under QOF. So to receive payment for a review, professionals simply need to tick that they've completed a review, and no additional indicators are in place to understand whether a quality review has taken place. And many people told us that their reviews kind of placed a narrow focus on their medical needs and not enough on their dementia-specific needs. And we also found advanced care planning conversations were not taking place during a review as frequently as they should. Next slide, please. So the next issue with these reviews is how holistic they are. So people with dementia are likely to experience co- and multi-morbidities, and these additional conditions impact how well people's dementia can be managed. So it's important that additional health conditions are considered holistically with dementia when conducting these reviews. Again, we found an issue with QOF, so its payment structure can perversely incentivize GPs to conduct separate reviews for each long-term condition a single patient has, because funding can then be claimed for each review. Next slide, please. And the last issue we found with these reviews is the frequency at which they occur. So professionals told us that reviews can sometimes reflect people's needs at just a single point in time. So a GP told us that at one annual review, everything can be fine. And then 2 weeks later, people can have a fall, get delirium in hospital, be discharged, and then go back into hospital. And they can have all these crises. And the care plan that was done just a few weeks ago becomes meaningless. And a reason for this is that we kind of found that the reimbursement structure of QOF can dictate the timing of reviews. So QOF is paid to GP practices right at the end of the financial year, meaning that the majority of reviews are conducted in March. And the graph in the bottom left shows the monthly difference between the proportion of people receiving a review. So as you'll see in 2018 and 2019, there's a 15% swing between the highest and lowest achieving month of people receiving a review. Next slide, please. I'll go through these very, very briefly, but what we kind of recommended when looking at these issues were to kind of support better access. We think that it's appropriate that national health systems ensure that when we do swing around to winter and winter pressures, that the COVID-19 booster programme does not unfairly burden GPs, and that the dementia QOF is never paused again. And we also believe that local health systems should support primary care to return to care plan reviews to pre-pandemic levels within the next year. To support a better quality review, we think national health systems should review QoF in conjunction with people affected by dementia and look to see if any additional indicators could be added to ensure it's a more quality review. To ensure a more holistic approach to annual reviews that encompasses all of people's health needs, we think that other primary care professionals, not just GPs, should be included to support these reviews, and they should also be staggered throughout the year to prevent many of them occurring in March. And lastly, to enable reviews to combat crises as best as possible, we think local health systems should ensure a system is in place to identify those with dementia who are kind of most vulnerable and at risk of crisis, who can then be offered more frequent reviews if needed. Next slide, please. So that's annual dementia reviews. So that was the kind of first part of the report, but we wanted to look at what people wanted from support after diagnosis more broadly. So here we identified a list of 9 outcomes, and then again we asked people to kind of rank them by their importance. So these outcomes were information and dementia education, person-centered support, emotional and mental health support, maintaining independence, symptom management, peer support and social contact, care continuity, cognitive stimulation, and finally carer support. So as you can see, people's support needs after diagnosis are kind of comprehensive and wide-ranging. It encompasses support not just for their medical needs, but for their emotional and social well-being. Next slide, please. So just very quickly on this slide, we looked at these outcomes and asked people whether they are currently receiving this type of support. So as you'll see, people have reported many unmet needs, and I'll go on to speak about these individually in the following slides. Next slide, please. So firstly is information and dementia education. So we found that people's information needs are not being met consistently, and over a third of people reporting an unmet need in this domain, often occurring when people are discharged too early from the memory service after diagnosis. Our report also found that people from South Asian community may be especially affected, particularly due to language barriers, with people often having to source information from non-formal avenues such as family members that work in healthcare. So we think that all memory services should be designed to offer at least a post-diagnostic support meeting after diagnosis. And this can help people first adjust to their diagnosis and then ask any follow-up questions that they might have. Next slide, please. The next one is kind of person-centered support. So we look to kind of psychosocial interventions, which we think that can provide people with that person-centered support that they need by focusing on what's important to them. But 50% of people surveyed that said that they did not receive support that treated them as an individual. And the challenge here is that when services fail to offer kind of psychosocial interventions, it risks over-medicalising dementia, places too much focus on people's medical needs and ignoring the social and psychological aspects of living well with dementia. The report also found people from the South Asian community may be adversely affected, particularly if interventions are not culturally accessible. So we think that access to these interventions should be a core part of local areas post-diagnostic support, and services should be designed to offer or at least refer onto these interventions. Next slide, please. So we know that depression and anxiety are common in people living with dementia, but 61% of people told us their mental health needs are not being met. And one research study we looked at showed that there were over 1 million referrals for IACT, so that is psychological therapies. So there are 1 million referrals to IACT in 2018, yet just 0.2% of these were for people with dementia. And this study also found that the structure of services are not set up to provide interventions for people with dementia appropriately. So we think it's important that these services do not reject referrals of people based on a kind of cognitive disorder, and that staff are trained around providing this support for people with dementia. And emotional support, kind of similarly, is kind of vital for people right after diagnosis, as it can help them come to terms with their diagnosis. But 60% of people told us that they're not receiving it. So we spoke to a few psychologists at Memory Services, and more or less unanimously, they told us that their time was kind of too often focused on the diagnostic workup of patients, and that they had little time to spend on support after diagnosis, such as counselling. So we think that psychologists working in Memory Services have kind of protected time to carry out any post-diagnostic support. Next slide, please. So in terms of maintaining independence, 44% of people reported to us they're not receiving enough support that enables them to remain independent, which is important given that almost 3/4 of people report unmet needs relating to daily activities. And we looked at occupational therapy here, and we think it's kind of key to keeping people safe and independent. So, for example, 17% of admissions in 2021 were for falls of people with dementia. But much like psychologists, we spoke to occupational therapists, and they told us that their time was also spent mostly on diagnosis, with not enough time available to support people after diagnosis. So we think that occupational therapists have protected time to carry out support after diagnosis. And in terms of symptom management, over half of people told us that they're not receiving enough support that helps them kind of manage their dementia symptoms. And we looked at this issue and kind of found that how Memory Services are commissioned and structured can be a barrier. So there was a big disparity between what people expect from a memory service and what services around England are generally commissioned to offer. So many people told us that they expected memory services to look after them for their whole dementia journey. And the kind of sub-issue here is that the availability of treatments for conditions determines kind of clinical pathways locally. And this kind of means that people with Alzheimer's disease receive more contact time with services and specialists, and then people with dementias other than Alzheimer's disease report feeling more or less abandoned by memory services. And this can be particularly impactful for people from a South Asian community. You know, lack of cultural support places too much focus on drug approaches to dementia. And so given this kind of disparity between subtypes, we think that services should be designed to offer equal support for all subtypes, including the interventions that people receive and also how long they stay with their memory service. Next slide, please. So in terms of peer support, 1 in 5 report an unmet need in this domain, and then 1 in 3 report an unmet need in kind of maintaining their social life. People from a South Asian community report specific benefit in knowing others from the same culture, particularly in cultures where dementias may not be explicitly recognised, and they can kind of share, meet with people and kind of share a similar experience. And here we looked at kind of social prescribing. So we think this can help support people's support network and maintain their social life through activities. But we know that nationally, targets for social prescribing link workers are not being met. Not only this, but the delivery of social prescribing is not adequately targeting people with dementia. So we think that national health systems should assess how social prescribing is being delivered locally to ensure there's equitable support, as with other long-term conditions. Next slide, please. So one of the biggest unmet needs that people reported was care continuity. So 2/3 reported that they're not receiving care that is consistent and ongoing. Now, care continuity is really, really important for dementia. Research shows that seeing the same GP consistently is associated with many outcomes. But of course, I'm sure everyone is aware GPs have limited capacity and there's potentially limited expertise at primary care level around dementia, which means people aren't consistently receiving the support they need. So there's a need to address these support gaps for people with dementia at primary care level. And so Of course, we know the incredible benefits of dementia support workers and what they can offer to people living with dementia. And we think that every person needs to access one. So we suggest that people are automatically referred to a dementia support worker type service to access one. And these are kind of integrated in DP surgeries, and particularly in areas of high ethnic minority populations. Commissioners should look to kind of input a community link worker element to this role. And what I mean by that is that the role could look to provide outreach to underrepresented groups and raise awareness of dementia. Next slide, please. In terms of cognitive stimulation, around half said they're not receiving support that helps them use their cognitive skills. But cognitive stimulation therapy, it's one of the few recommended, nationally recommended treatments for dementia, is only available in 3/4 of services. So we think it's important that all services can offer or refer onto the intervention in the next 2 years. And the biggest, out of all of these kind of 9 outcomes, the biggest unmet need reported to us was support for carers, and over 2/3 reporting an unmet need in this domain. So essentially, the complexity of the health and social care system means that there are widespread gaps in kind of information on and access to carer support. People from a South Asian community may be adversely affected. Essentially, they're caught between a rock and a hard place. They cannot source support from formal services due to a lack of cultural accessibility, but sometimes can also not source support from their own community where dementia may not be explicitly recognised as a health condition. And strikingly, we found only 1/4 of services were able to provide or refer onto a carer psychoeducation course. So it's important that all carers can access this support and sufficient information is provided to carers. Next slide, please. And just moving on to the final few slides. So our next kind of research question was looking at what is the impact of support needs not being met. So firstly, we looked at hospital admissions for people with dementia. And admissions are often associated with a poor care experience as well as poor health outcomes. So we think there's a need to prevent admissions within the community, and we know that almost 9 in 10 admissions of people with dementia were for people who lived in their own home. And we also know that many admissions may be unnecessary. So the graph on the left shows that almost 1/3 of hospital admissions were for a day or less in 2020-21. And this essentially suggests that better community care could be provided to reduce these admissions. And then the graph on the right, so we looked at UTIs, falls, delirium, and chest infection pneumonia. We saw that these 4 conditions accounted for over 350,000 admissions for people living with dementia between 2015 and 2020. And these are common conditions, which some could be avoided or their harm at least reduced by appropriate support in the community. Next slide, please. And just very briefly, these people obviously do experience poor health outcomes when going into hospital admission, when having a hospital admission, but in terms of the system, these admissions cost the NHS almost £1 billion between 2015 and 2020. And as mentioned, 1/3 of these admissions are for a day or less. So if these could be prevented, the NHS would have saved £326 million. Next slide, please. We also looked at not just kind of hospital admissions, but we looked at what the impact is on people and their families. So for the impact on people affected, our engagement found carers regularly reaching breaking point, stressed and unable to cope with demands of caring. And despite the impact of caring on their mental, physical and emotional well-being, carers experienced feelings of guilt when they could no longer safely care for their loved one, and consequently moved them into residential care. And we also found that lockdown measures due to COVID-19 and closure of services meant carers couldn't regularly access support that supports them in their caring role. And 54% of carers told us that they reached a crisis point in the previous year. And COVID-19, of course, has also had an impact on the deterioration of people with dementia. And 84% of carers told us that their loved one's health and well-being declined in the previous year. But this view was also shared with commissioners and services who said they saw a faster deterioration of people with dementia during COVID-19. Next slide, please. I think this is the last slide, but so we know crises can have an adverse impact on people affected. But how can these be reduced? So we believe that a stepped model of dementia care can proactively reduce crises. So for instance, what I mean by stepped model is that it could involve a dementia support worker who can provide lower levels of support, such as information provision and signposting to community services. If needs exacerbate, then they can be easily transitioned to a more specialist support, such as an admiral nurse or an advanced nurse practitioner, to get that more kind of specialist support. And when these needs have been addressed, they can then be stepped back down to the dementia support worker role. But of course, inevitably, some crises will kind of be inevitable. So when they do arise, there's a need for local areas to kind of provide immediate response. And under the NHS long-term plan, urgent community response teams are designed to deliver emergency interventions to support community care in the event of an individual health crisis. But we think these teams must have good kind of dementia-trained geriatrician support. And NHS England, we think that they need to kind of commit to review to the provision of these crisis teams, as well as providing a timeline to the second phase of these teams, and that's re-enrollment packages. So these are packages of care offered to people within 2 days of a crisis occurring, ensuring that people with dementia receive longer-term support to recover from a crisis, else it risks that crisis merely just being delayed. Next slide, please. So we got to the kind of end of the presentation. So I guess for some kind of takeaway points, in terms of the support, over 2,000 people affected by dementia told us what they need after diagnosis for their medical, social and emotional needs. But this report shows that these needs are not regularly being met, how services are commissioned, and the lack of integration between services inevitably means people cannot access care and support that is both timely and appropriate. And this report also shows that when support needs go unmet, it increases the risk of crisis. So that brings me to the end of the presentation. Hopefully it wasn't too boring for you. So thank you for listening, and I'll pass over back to you, Ian.
Thank you, Keelan. That is an excellent presentation, incredibly thorough, and it just shows the complexity of the challenge and the issues. Something as simple as supporting someone to live well and understand the impact of their dementia, and then to organise the support that people require to really focus on what's really important, what matters to them and their families and their relationships, is actually incredibly complex when it's trying to be understood through the system. So thank you for the report. There is an awful lot of information there, so we have recorded it and we will be sharing the video presentation. But also we'll give you copies of the slides as well. And also to remind people that there is a detailed report from the Alzheimer Society as well, so make sure everybody gets the links for that as well. Just before I introduced conversation with Philippa and Ian to get a sort of a personal reflection of their own experiences of post-diagnosis support, can I just ask Kira, because I know that there's quite a lot of activity in the comments, which is great, and keep adding those comments because we will go through each one of them. But is there anything there that you want to sort of draw out and sort of add a bit of detail from the audience?
Yes, thanks. So with the comments, we will save all the chat as well, so that all of that can be included in our post-event write-up. So do keep leaving comments in there. Kate White has highlighted a quote from the report, which was, I don't know what there is, so how can I know where to go for support? And she says, it's a very telling quote from your report. This includes access and importance of people being able to participate in creative life, in music, art, sharing activity with people in nature, etc. Julie Hayden has said that an increase in appropriate support would lead to less depression and less reliance on mental health services. And Linda Burgess has also commented that she'd like to see the separate responses from people diagnosed with dementia and carers. They don't always necessarily share the same perspective. So thanks a lot, everybody.
Thanks, Kira. Yeah, and I think that separation between experiences of the person with dementia and also their family and carers is an important one and a crucial one. And the DCAN view really is that it's around relationships and how people get supported. You have to take it into account both. And it's probably a good introduction to the next section of today's event, which I'm going to have a very brief conversation with Philippa Russell and also Ian Deacon, just to hear from their own personal experiences of the support that they received at diagnosis, but also their ideas and thoughts on how it could have been improved or what may have been missing that we can begin to address. So Ian, could I start with you just to introduce yourself, but then go on to talk about what your experience was like immediately following a diagnosis of dementia and the kind of support that you received?
Yes, sure. Thank you very much, Ian. In June 2019, it had been noted by my family that my short-term memory had diminished. So I went to the doctor and I was referred to the memory clinic. And at that stage, I was diagnosed with mild cognitive impairment and had an MRI scan. Going on then up until January 2021, my daughter felt that I probably needed to have a further scan as she considered there'd been some deterioration. And I then had a CT scan and discussed that, or I didn't discuss it, but I awaited from the doctor a report. I did in fact have a telephone conversation with the doctor at the memory clinic, and he told me that I got mild cognitive impairment, and I was concerned whether I had dementia, and I actually asked 3 times, have I got dementia? And I was categorically told, no, you have mild cognitive impairment. So in April 21, I was somewhat staggered when I received a copy letter from the memory clinic doctor to my practice doctor to say that I got vascular dementia, which was completely out of the blue and against what I'd been told. I made contact with the memory clinic to say, has this been a typing error? Has something gone wrong here? And I was told, no, you do have vascular dementia. That came as quite a shock to me. And I'd also discovered as well at that time, because my daughter then saw the MRI scan from 2019, that I'd also had a stroke, and the memory clinic had never advised me of that either. And so it wasn't until my daughter saw that report that that became evident.
Ian, could you, so once it was clear that you had vascular dementia, what kind of support was offered to you to understand what that meant and begin to process that and begin to reflect on the support you might need going forward?
The only support I had was that I had a letter then in August 21, and this letter said care plan, and basically it was a list of organisations that may be of help if I wish to avail myself of their services, and that letter then discharged me from the memory service. It did say that there would be a follow-up and post-diagnostic counselling in 4 months, which I still haven't received, and I received no contact from them. I also made mention at the time that it had affected me quite badly, the shock of realising I had dementia in the way that I was told, and that I'd never suffered with depression in my life before, but this had really hit me big time. And I spoke to my own doctor, and they told me to go to a man's club, and then they told me to go to a telephone number to contact a local counselling service, but the man's club was of no value to me whatsoever. And the local counselling service was basically, and I don't mean this in a detrimental way, but it was a young man who had no experience of the condition at all. So that wasn't of service. So I basically came through that process of depression, fortunately, reasonably quickly because of the nature and the kind of person that I am. But I had no help. And it took me 5 telephone requests to the Alzheimer's Society to try and get somebody for me to be able to speak to. And eventually I had that. So sadly, my report is that I had no help whatsoever. And also, I understand that there is a 12-month review, and it wasn't until yesterday that I found out that that was in existence, and I haven't received that either. Not a complaint, it's an observation.
Thank you, Ian. I'll come back to you. I was going to bring Philippa into the conversation, but I'll come back to you in a moment just to think about what could have been different and how you would have liked it to be. Philippa, could I just ask the same of you, just to introduce yourself and a little bit about your experience of post-diagnosis support for your family members?
Hello, everyone. I'm Philippa Russell, and I'm Vice President of Carers UK, and therefore I have a lot of carers stories about diagnosis and what came or didn't come after. But I'm just about to say a few things about my own family experience, which actually includes 3 family members. My mother had dementia, vascular dementia, died 15 years ago. We had no support post-diagnosis whatsoever with her. I relied on my own knowledge of how the care system worked in getting extra support. She wanted to remain at home, and using the Alzheimer's Society for advice. But I felt doubly dispirited when my husband was diagnosed with Lewy body and plus frontotemporal dementia 5 years ago. Alan actually died just over 2 years ago. He died with dementia, but he actually died of cancer and heart failure. And our experience really showed me that we need a new narrative in talking about dementia. For Alan's cancer and Alan's heart failure, we were immediately given time with a consultant. We were given a care pathway. The outlook was bleak in both cases. There was no cure. He was terminally ill, but the emphasis was on living well. An occupational therapist was offered to have a look at the house because Alan was having a lot of falls. We were put in touch with support groups. There was a Macmillan nurse and a specialist cardiac nurse. When I asked about an Admiral nurse, because Alan's behaviour, which can happen with some dementias, could be very, very, very difficult. And it was quite clear that we would have difficulties, for example, in using the local hospice service. And it was difficult at home because I have a disabled son living at home, and he was sometimes sadly frightened of his father. And Alan was a wonderful father, but when he had what he called his black moods, it was very different. And I did actually, in the end, via the oncologist, buy into some private support. And we did make a plan, and I paid for annual reviews. There were annual reviews and more frequent reviews sometimes for Alan's cancer and his heart failure, but there was absolutely nothing to actually monitor, to support, advise how he lived well with dementia. And you can live well with dementia. My mother had her unhappy moments, but she'd been a professional classical concert pianist, and we kept her piano. And she actually did move to a care home in the end, which was her choice. She went for respite care when she'd more or less wrecked the house with the gas explosion, and decided she would never leave what she called her very nice hotel. And she played. She couldn't read by then. She didn't talk very well, but she could play any of the classical concertos, sonatas that she played before, and she was a pleasure to everybody and to herself. And I wanted to make that point because talents can survive with dementia, and a lot of people think they can't. And some of Alan's talents, he'd been a very able and successful man, they succeeded. He wrote quite a lot, not on dementia, but the dementia was always there, and I felt it disqualified him from life. And one of the big challenges, and I learned something very important from my sister-in-law, and I'll end here with personal comments. Doreen died 6 years ago, I'd known her for 75 years. She'd been my best friend. Our families came over from New Zealand together. She married my brother. Because she was here in the UK on her own, I had lasting power of attorney. She was a distinguished scientist in her own right, and she diagnosed the dementia, vascular dementia. She had COPD as well. And she went straight out, and I don't know whether people would agree with it. She actually found her own private diagnosis. And she said, I'm still me with dementia. I'm still capable of making decisions, and I'm going to make decisions about my care. And she actually did, we did together, really, I think, co-produce as good a life as she could possibly have had. And I wouldn't fault the hospital staff. She was in and out of hospital with the COPD. We were lucky because of her personality and determination. And I regret to say, because of her money, because I was able to afford really good live-in carers who enabled her to remain at home. There was a team around Doreen in the end for her last 2 years of life, and they were good years. There were the live-in carers, there were the home carers that relieved the live-in carers. There was a gardener that did odd jobs in the house and looked after the car. I mean, I've never lived like this, but Doreen did. But I saw her flourish, and although we can't replicate that life for everyone, she had absolute confidence in telling everybody, all her former colleagues and friends. She said, I have dementia. If I had cancer, I'd talk about it. If I had muscular dystrophy or a host of other conditions, I would talk about it. It would be interesting. And one of the things she was really angry about, and this angered me in trying to care for Alan, was the way that dementia is often portrayed in the media. The pictures are always of victims, or too often of victims, of people sitting there looking helpless, being entertained by loving care staff. But a lot of people with dementia, if they're supported, can do a lot of things for themselves. Think of the fantastic Wendy Mitchell. And with Alan, his behaviour reminded me that sometimes it's sorting out one part of somebody's care pathway that will enable them to have a good life. And if I'm angry about anything, it was the terrible difficulty we actually had in getting help and advice in managing Alan's occasional black moods when he could really be quite aggressive. The help that was offered me was a referral to the local women's abuse centre. I'm not saying it was entirely without use, but I wasn't an abused woman, and I didn't feel very happy going down that route. My best help and advice came from a lovely community police officer that I had to call on a couple of occasions because I was worried about Alan's safety, wasn't worried about my own. And he gave me some very useful top tips, but he said to me, my dad's got dementia. He said, we could do a lot more about helping carers like you know more about anger management and behaviour. And most people would never have those outbreaks if they had dementia. So really what I would feel in conclusion from those three experiences, we do need a new narrative. We need to talk openly and honestly about dementia because many of us will get it. We must have a proper care plan, a care pathway, which is regularly reviewed, because how we progress with a condition will be as variable as it might be if we had MS or a range of other long-term conditions. We have to look at how we can actually support people to live well in their own families and their communities. And I do know from Carers UK and from the study that's just been quoted that a lot of us who are carers, particularly with the pandemic, have felt absolutely wrung out and exhausted. We need people to help us. And I just so wish I could have had an Admiral nurse or somebody or a dementia support worker who would walk along the pathway with me, be available for instant advice or comments, and would help me see that hopefully I was actually doing the right thing. I do think Alan had as good a life as he could have had. I think my sister-in-law did. And if I'm proud of anything, well, I'm not proud. I'm proud to have been part of co-production. You don't do this on your own. But I'm very sad that it actually took so much effort. And I think we, as I said, I'll end where I began, I think we have to have a new narrative, an open and far more positive discussion about dementia, so that people can feel, as my sister-in-law did, and it worked very well, that you can tell people that you've got dementia, just as you might tell them you've got an allergy to something. It's just part of you. And we can look at health and well-being and not focus on what we see, a downward spiral for a condition which nobody can do anything for. You can still live good lives with dementia, and we need to celebrate. We're not victims, we're people and citizens, but we do need support.
Well said, Philippa. Thank you very much for such a clear and powerful articulation, and lots of ideas that hopefully we can take into the discussion groups as well. And I'm glad we've got that recorded and we can share that as widely as we possibly can. Just before we do go into the breakout groups, can I just come back to you, Ian, and something that would have made a difference to you, if you could name one thing that would have transformed or got you to a better place quicker, what would it have been in terms of the support you received at diagnosis?
I think a follow-up, because there wasn't any at all. And also for someone to ask me, how did I feel about it? What was the impact on me? Who was it? Inquire about my circumstances. Who will be your carer? How do they feel about it? So none of those questions were asked. And even when I pointed out the discrepancies and the errors, there was just an enthusiasm to address that situation with no care or concern of how it had impacted me, or it addressed and say, well, let's sit down and talk with you. I was never invited back into the memory clinic to have a discussion. Those kind of things hurt. And I felt as though I was discarded. I was now diagnosed with dementia, but nobody particularly wanted me. Because you think irrationally at those times.
Thank you, Ian. And I think from both of your contributions have been very powerful and very personal. And thank you very much for speaking up, because it's not an easy thing to share such personal experiences in a group. And I think it really does help shine a very real and powerful light on the issues that are involved. And I think the really sad thing that strikes me from both your contributions really is how much of it is just recognising the human element and the human quality of effective post-diagnosis support. And when that's lacking, the damage that can do. And yeah, I think, I don't know, I don't need to add anything else, because you said so much, again, with such humility and power. So thank you very much. We're going to move straight into, just because of time, I think I just wanted to hear both Ian and Philippa talk in as much detail as possible. So rather than go into an open Q&A, we're going to go into breakout sessions straight away. So do please contribute your ideas. We're going to have 2 questions for the breakout groups because of the numbers. We think we need to have it quite tight. So the first question really is, what do people want from post-diagnosis support? And if you are a carer, or if you have dementia, you're in the breakout group, you can speak from personal experience, but also from professionals as well, and your observations and the people that you've known and worked with. What do you see as a priority? What is the support that people are looking for? And we've had many examples in the presentation and conversation today. And also then, what do we think are the challenges in delivering this? Because at one level, they're very human and very simple, but we know from experience and how rare they are, how difficult it can be in the context of a system and supporting lots of people through diagnosis. So before we can really move forward, I think what we really need to understand as a network and as a group is to really get underneath what the challenges are in delivering those things. So the breakouts should happen automatically. You will find yourself in a breakout group shortly, and then we'll be brought back into the main group as automatically as well at the end, and there'll be a chance to give a brief summary of those discussions. We'll also be taking notes, although we won't be recording, so we'll be able to capture some of your contributions in the notes and the feedback from today's event. So who wants to go first? I'm trying to remember who
I can, if you want.
Yeah, go on then.
So we talked a little bit about how people really do appreciate having the continuity of care and having that named professional all the way through. People also shared that people really like to be able to talk through the journey of like where they are right now, what the next steps are, just to kind of understand the process. So people found that quite useful, and being able to offer people support not at the point that they're in a crisis, so something that's ongoing and helps people avoid getting to that point. And the other areas people thought would be really important would be just having some ongoing support. So people often described it as the support just going off a cliff edge and disappearing. So having something that is ongoing with accessible communications, empathetic communications from professionals, and just making sure that the communications and human touch is there and it's not just very cold and clinical. In terms of the challenges, we said about staff and numbers just always being something that's quite difficult, and even some of the areas that we were discussing have really innovative things that they've kind of done to meet some of the challenges that were identified, but still it's a challenge because the demand is just so high. We also talked about commissioning, so a lot of services are commissioned to just be a dementia assessment service. So actually there isn't the funding there to do the post-diagnosis support. So maybe there's changes that's needed for commissioning. And like timely intervention again, and making sure that if people are getting ongoing support, they don't come back in a crisis, which is then maybe very difficult to work with people and end up working more with families. So having something that goes ongoing and helps people like plan for the future would be really useful. I've got loads more, but I'll save it for the write-up and share.
That's great, thanks, Kira. Keelan, can I come to you next?
Yep, sure. So I guess the main thing that came out was the need to look at people and their families kind of comprehensively, not just kind of looking at a diagnosis and what they need medically, but looking at you know, their social and emotional well-being, looking at the person's kind of care network, and again, as in kind of Kira's group, valued that kind of care continuity, and people didn't want to feel like they're being discharged, but there's always kind of someone there for them if any issues arise. Did hear about a good, I forgot where it was, some part of England, where people newly diagnosed were kind of hearing from people already with a diagnosis to kind of provide a co-produced peer support. So that thing around kind of peer support and you know, going through a diagnosis can be particularly challenging. You just want to hear from someone who's kind of knowledgeable and experienced of it, who's been through the same kind of situation, can be quite beneficial. We had a big discussion on the challenges actually. So the structure of services, again, like in Kira's group, and how they're commissioned. It's difficult for memory services when it comes to evaluating their service to commissioners. There's no kind of outcome measures or metrics, but there is a diagnosis metric. So a lot of the money just gets funneled into diagnosis, and then little to yeah, next to nothing for kind of post-diagnostic support. So there's a challenge of kind of yeah, influencing commissioners to actually say this is the point of the diagnosis, to actually get that kind of care and support. Yeah, and again, linked to structural services, kind of workforce is kind of an issue as well. Dementia prevalence is always going up, so that means the need for services is always going up. But I guess the workforce and money within kind of dementia services is not kind of keeping up with that. I just think I've scribbled down some notes, but yeah, I'll leave it there. I could go in for ages, but yeah.
Good summary. Thanks, Keelan. Jo, were you facilitating one of the groups?
Yes, I was. And I'll just say, we were just talking right up to the last minute and it cut Philippa off. So Philippa, we loved your chat at the end. So thank you so much for that. So one of the areas that we talked about was the sort of blurred area when somebody's not sure if it should come under social care or health care, and then they end up sort of being lost from the system. And then sometimes the only way back into the system to be sort of linked up is when there's a crisis. but it would be better if there was some support before that to stop that from happening. We talked about not having the time, staff, the budget for people who are working in dementia care and support to really give the support that they would like to be giving. We spoke about how this is a bigger political issue, and it's, you know, it's something that really goes beyond everything, and we'd love it to be escalated even further. We also discussed how supportive peer support can be, somebody that you can relate to, somebody who's been through the same thing as you, and having good signposting to that is really important, and especially also for people with dementia who are younger. So that's an area which doesn't always have the same support. So that would be really helpful. I think maybe the main takeaway was communication, how people aren't always sure what support is available, and there is support there, but it's just not linked up, and people don't necessarily know where to go for certain things. And if sort of everyone in the Dementia Network was communicating perhaps a little bit better, then we could really support people in a better way. And we've got 2 minutes left, so I'll leave it there. But thank you for everyone in my group. It was a great chat.
Great, thanks, Jo. Was it just me left, or was there another group?
And me.
Who's that? Sharon?
Sharon.
Sorry, Sharon, your group.
I'll do 30 seconds really quickly. There was lots of discussion about IAPT support for people with dementia and people who are carers to get more psychological support and how that could be funded. There was a lot of concern brought up around end of life, actually. People feeling that they weren't entitled to services or didn't know how to access them or weren't told about them. People not really understanding what end of life looked like, which obviously added to the trauma. We did have some good examples of what that looked like. Judy talked about the people in her area that are given supported palliative care as part of their journey. I think there was a recognition by one of our commissioners who was saying it's hard to make sure that there's a care coordinator for everyone and they understand the importance of doing it, but it's hard to implement in practice. And I think there's also something around commissioning where things are commissioned for maybe a year and then it's pulled, or someone gets offered to serve 3 years and then it disappears. And there seems to be a lot of concern about what impact that has on staff, on the people with dementia, and also on trying to generate services that then prove that they work, because obviously you're only going for a year, you don't get much further. I'm going to end it there because we're tight on time, but I just wanted to say thank you to everyone who shared their stories, especially around end of life, because we know it's hard to discuss. So thank you.
Brilliant. Thanks, Sharon. Well said. Just again, very quickly, a lot of similarity in themes. Continuity was a big one from our group, and how difficult it is for the professional having to hand over to someone else when they've built that rapport and that relationship, and that those individuals have shared a lot. And sometimes that can be part of the barrier, and that becomes someone doesn't actually follow up with what is available. It's not always about there isn't post-diagnosis support. Sometimes people choose not to engage at that time. And one of the suggestions to overcome that would be to be more proactive. And if someone says no there and then, go back in intervals and just check in on people to see whether the support that is available is useful at a later stage. There was a lot of discussion around the need to separate out people with dementia and their family and carers, and making sure that, yes, they get support and information together, but also each person has an opportunity to be heard and be listened to and have their own unique personal needs met at that time. And tied to that was a lack of education and support, and a failure to recognise the impact on family members and carers in dealing with certain situations that may or may not arise following the diagnosis of dementia, and the need for education and proper tips and support for people. And I'll just end on a positive from the example from Somerset, where they've been rolling out an education learning program that brings together the carer and the person with dementia initially. Then there's theme sessions just with the person with dementia that comes back together with the family members and carers at the end. And that's been having a real positive impact, although it's quite early days. And from that recognition that similar good practice, things like the CRISP program at Alzheimer Society, a lot of what is needed does exist. What isn't there is knowledge and awareness of all those things and the good practice that's emerging in pockets. And also it was raised the need to get that political buy-in to make this a priority and to give parity to dementia and give it a profile and an importance within commissioning, and to really focus in on who funds this support. It's not a case of not knowing what's needed, it's a question of the challenge of dealing with the numbers, the complexity and the personalised nature of post-diagnosis support, and ultimately it comes down to funding and who's going to be responsible for making sure these things exist. But again, like everyone else's group, it was a very engaged and a very informed conversation discussion, so thank you everybody from the group. I imagine, as I normally do, is I've probably talked over the end. So just to say, everybody who signed up for today, whether they've been able to make the session or not, will receive a recording of the full group elements, not the breakout groups, but we'll also be sending through notes as well. But we won't end there. A lot of the themes and ideas and priorities that have been raised today will become part of ongoing work with DCAN and our partners, and there will be probably more targeted and specific discussion groups that will fall out of some of the points raised today. So just to thank again the speakers, Ian and Philippa, for your very powerful personal contribution, but thank you to everybody for giving up the time today and also for being so free of your own ideas and contributions in the breakout groups. So thank you everybody, and goodbye.